and understanding of physiology is very important because it will help you out in terms of evaluation, management, and overall pathophysiology in that regards. So today we'll talk about the basics of endocrine physiology. What really is an endocrine gland? What are hormones? How do they act? How do they interact? And in that, we'll also put some case scenarios to really highlight the interaction between physiology and how this physiology helps you identify in terms of pathophysiology. So when we talk about hormones, there are two basic type of hormones, largely the ones which are large, which are not going to get into the cells directly, which will easily go into the circulation, and they are responsible for regulating usually the chronic process. These are the peptide hormones. Then you have small hormones, which are lipophilic, which can easily go in and out of the cell, but they cannot travel the blood. These are the steroid hormones. And then you've got the third category of bioactive amines, which is basically catecholamines, which are small amino acid derivatives, which are a mixture of both these functions. So hormones could be peptide, which are small peptides which are coming from the hypothalamus, largely the CRF, the AVP, which is the smallest peptide hormone. TRH. How many? 3. And what about AVP? Yes. So these are all hypothalamic. They don't need to go to a long distance from that perspective. So all these hormones are very, very small. But when you talk about complex, like growth hormone or prolactin, you will have large chains. You will have multiple chains like alpha and beta, like LH, FSH, HCG, TSH. Insulin has got 2 A and B chains, and IGF-1. They usually have a regulatory effect. Steroid hormones, we all know, all the gonadal hormones, all the adrenal hormones are largely steroids, and they are usually slow acting in that regards because they're going to act through the receptors which are going to act on the nuclear receptor, and they are regulating the protein synthesis. And the amino acid derivatives, largely epinephrine, norepinephrine, you can say thyroxine also in this regards, are fast acting hormones in that perspective. So we have got large peptides like growth hormone, small peptides like vasopressin or TRH, which are largely hypothalamic of origin, glycoproteins like FSH, LH, TSH, and HCG. You have got dual chain peptides like insulin. You've got steroids like cortisol and amines like epinephrine. So these are the different structures which are there. Now, what is the basic difference between the two? So peptide, I said, are very, very water soluble. So they are lipophobic or hydrophilic. So they love water. They will just go through. They don't need a binding protein. So they can go directly. But some of these peptides do have a binding protein. The classical example, Vibha, is growth hormone. And the growth hormone binding protein, what is it doing? Why is it there?
It stabilizes the levels of growth hormone, and it carries the growth hormone from the follicle.
Yes. So there are multiple effects. As you said, that of course, if you have a binding protein, if suppose you have got somebody who is unstable and he just goes here and there, you have got somebody who is along with that, they will keep him stable. But the most important part is it is going to take it to the site of action. And the growth hormone binding protein is very unique. It is the extracellular domain of the growth hormone receptor. So where it will come from? So it will come from the places in which growth hormone receptor is there. So it is going to come from there, and then it is going to take it there. So it's like somebody is doing fishing. You put your basically the bait, and this growth hormone binding protein is like the bait. This is the extracellular domain of the receptor. It is going to take the fish, bring it back to that site. So in a way, growth hormone is so precious. No other hormones has this sort of a scenario that the site who want growth hormone, they actually send their signal. Okay, bring him there. They will get the growth hormone here so that it starts acting. So this is an interesting scenario. So binding protein is usually not required, with the exception of growth hormone, but there will be a lot of peptidase which are going around. So all these peptides, once you get into the blood, they are going to be destroyed. AVP, few minutes, CRF, few minutes. So most of them will be degraded immediately. GLP-1, degraded immediately. So all these will be degraded very quickly. So this is something half-life becomes short. Now they cannot enter. So they are like, they cannot be allowed inside the cells. So they will have to act through a receptor. So they will do a bell, they'll ring a bell and that bell will cascade the system. So this is an extracellular system which is there. In the system of peptides, you have got a multiple overlap. So classical example is these glycoproteins. You have got alpha and beta subunit. Alpha subunit is the same for TSH, LH, FSH and HCG, and the beta units are similar. So what it tells you is that if your TSH is very high, it can act on the FSH receptor. If your HCG is very high, it can act on the TSH receptor. So this sort of an overlap can happen. So classical interesting scenario, very high TSH, it is going on to act on the FSH receptor, and in girls it is going to cause ovarian cyst. So untreated prolonged hypothyroidism will cause von Wieck-Grumbach syndrome, which we discuss often in that clinical perspective. The analogous to this scenario is the effect of TSH on the testis. So TSH is going to act on the FSH receptor and enlarge with cells, Sertoli cells, with minimal effect on Leydig cells. So large testes, which are useless, which are not producing testosterone. So you have got a strange scenario of no pubic hair and macroorchidism. So macroorchidism in a short child may be the only sign of hypothyroidism. This is something to remember from that perspective. Now, placenta produces HCG, which can act on the TSH receptor, which will then cause thyrotoxicosis. So all pregnant women have a slightly thyrotoxic state and their TSH goes down by 1 unit. So the cutoff of TSH in pregnant women is 4 rather than 5 or 5.5. So this is because of this HCG effect, and by 3 months or so this HCG will come down and this process will come down. A lot of women will also come to you with features of mild thyrotoxicosis, tremor, they will have tachycardia, the TSH is low, and they don't have any eye sign of goiter. You don't need to do anything. You can wait and watch and they will improve on that perspective. Now, HCG is actually same as LH. It has got the same effect. So if you have got too much HCG, it is going to cause an increase in the testicular production of testosterone. Size will increase gradually, but you will have much more testosterone. So HCG producing tumor will have a scenario of intermediate side testis with precocious puberty. So if you understand these, it becomes very easy to go back to understand that. Steroids, on the other hand, are actually fat soluble. They cannot go in the water. So they will have to be carried using a binding protein. And this binding protein is not only stabilizing it, it is also increasing its half-life. It is also directing it. Okay, go to this site. This is your site of action. And they will have a high protein binding. And because this protein, it's not just they are bound. You can think of like, this is like a big ship or a boat in which this steroid has been there. So the sharks cannot come and attack it. While the peptides are going alone in that path, many of them, these peptidases are acting like sharks, they're eating up. While steroid hormones are in a way precious from that perspective. So they are being carried in a coated environment and they are being taken safely from this place to the other place. But once they go into the cell, they will immediately leave the binding protein and they will go inside the cell directly. So they will have direct penetration, and then they're going to talk about work on the nuclear intracytoplasmic receptor to activate the transcription process, which is there from that regard. So this is the major effect. The amino derivatives like catecholamines are intermediate. They will have, they are water soluble. They can have, they don't have a binding protein basically. They have a low protein binding, but they have extremely short half-life. So you don't want your epinephrine to be there for hours. You want it to be killed immediately. They have a small, ultra short half-life, and they have effects both on the cyclic AMP receptor as well as the thyroid, which has got a nuclear receptor in that perspective. We'll talk about that much later. So if we now compare about the different types of hormones, peptide hormones are usually large. They have very limited protein binding except for growth hormone and IGF-1. They act on the membrane receptor to cause immediate effect. So they have a rapid effect because as soon as you have got this receptor action, your cyclic AMP, cyclic GMP, nitric oxide, IP3 DAG, whatever pathway comes in, it becomes active. Half-life is short. The effect is in the medium range. Steroids are basically intermediate in terms of size. They're not that big. They have got a lot of protein binding. They have got an intracellular receptor, and they can be a slow process. They're regulating pubertal development in terms of other aspects about reproduction. So these things will be there. They have a long half-life because peptidase are not there for them, and they have a slow action. While biogenic amines are very, very small, they don't bind with the binding globulins, both extra and intracellular receptor, very rapid action, very short half-life, and rapid effect.